Over to you, sir.
Yeah. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room, experience with Carbetocin. This program is brought to you by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company with 25 years of excellence and 36 state-of-art manufacturing facilities. Hetero Healthcare has 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. It's amongst the largest manufacturers of ARV, APIs, and FDFs in the world. Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and Hetero Healthcare has distinction of bringing 4 biosimilar products to market within 5 years of initiation. This program, Case Studies from Labor Room. Today we have got Honorable Speaker Dr. Kishore Pandit with us. Welcome, sir. Welcome to this webinar.
Thank you.
Dr. Kishore Pandit is MBBS DGO with fellowship in IVF from UK and diploma in laparoscopy, Kiel University, Germany. Sir has undergone training in office hysteroscopy from Italy, training in pelvic endometriosis and laser surgery from Austria. Currently visiting gynec laparoscopic surgeon, BJ Medical College at Sassoon General Hospital, Pune. Founder, trustee and secretary and medical director, AIMS Hospital and Research Center, Pune. Director and IVF consultant, the Birth Company IVF Center, Pune. Founder, president of Pune Association of Gynec Endoscopic Surgery.
Including this. कुठे कोण नाही झाली म्हणजे अच्छा आपलं हे नाही
Sorry, sir, I got logged out in between.
Okay, fine.
Just 1 minute. Yes, sir. Over to you, sir.
Yes. Okay, where is the first slide? It's the slide number 5. Good afternoon, everyone. Today we will talk about a common but very important topic of PPH. Now, this is in day-to-day practice. We see patient of PPH and constantly we are thinking about the remedies we should use to control the PPH. Now, why to switch? Because we all are happy with our present tocolytics. Like everyone is using oxytocin. So many of us will think that why to switch from a known molecule to a new molecule. Now see, when I started my practice 25 years back, that time I have started with general OBGYN, and slowly I have shifted my practice to laparoscopy and then IVF and then now robotic. So we always thrive for new things. And of course, it is for the benefit of the patient. So whatever is good it comes out of research, lot of research that we should definitely opt for. And before that, we definitely want to know what exactly is the benefit in terms of the cost, in terms of the safety. So today we will go through all this. Cost, I think the people from Hetero Healthcare will let us know. And rest of the clinical things we will discuss. Next slide. Hello. हँग झालंय का? नाही, नाही. Everybody can listen to me, right?
Yes, sir. Yes, sir.
Okay, okay. Fine. I thought I'm just talking and nobody is
No, no,
listening.
no. We can listen, sir, clearly.
Okay. And how many people have joined?
So that we will not know because the link is separate for people joining. That's a YouTube
Okay,
link.
fine, fine,
That's a
fine,
Zoom.
fine.
Yeah.
Okay, fine. So all of us know that PPH is a very daunting event. When do we call it as a PPH? That is a loss of at least more than 500 ml blood following vaginal delivery and 1000 ml following cesarean section. So PPH is very common and can occur in women. So what do we do about reducing the blood loss? So we'll have to think about the prevention in the patients who are at risk of PPH. We can think of prevention and accidental PPH, or when it comes, then we can think of how to avoid it. Next slide, please. So PPH, it's very unfortunate, but it is very common also. So it is a major cause of maternal mortality. If you see the developing countries and developed countries, the ratio is like 240 per 100,000 live births compared to 16 in developed countries. So we are into developing countries, so we should probably pay attention to this more. How to prevent the PPH? See, when it happens, then definitely we use a lot of things, a lot of guidelines are there wherein we can arrest the blood loss. But the time has come wherein we should think about the prevention of PPH. Next slide, please. So all of us know that etiology of postpartum hemorrhage is tone, related to tone, thrombin, trauma, and retention of the tissues like placenta, blood clots, and of course abnormal placenta also. In tone, if you say, there is uterine atony. So inability of uterus to contract, which may lead to continuous bleeding. In trauma, uterine trauma, injury to birth canal, rupture and uterine inversion and laceration. So all these are the factors which contribute to the postpartum hemorrhage. So we will see one by one how this new drug or how our present drug acts on the uterus to control the postpartum hemorrhage. Next slide, please. So, clinical findings in PPH is abdominal tenderness, circulatory collapse, increasing abdominal girth, loss of uterine contractions. There is maternal tachycardia and vaginal bleeding. This we are talking about the vaginal delivery. And blood loss is around 500 to 1000 ml, which is compensatory. And in mild degree of shock, it is more than 1000 ml but below 1500 ml. The moderate degree of shock is around 1500 to 2000 ml, and severe is more than 2000 ml up to 3000 ml. So, in compensatory, there is no change in blood pressure. In mild degree of shock, there is slight fall of systolic blood pressure. In moderate, there is marked fall of systolic blood pressure. That is, it can come down to 70 to 80 millimeter of mercury, and profound is almost up to 50. Symptoms and signs are in compensatory, it is palpitation, dizziness, and tachycardia. In mild degree of shock, weakness, sweating, and tachycardia. In moderate degree, restlessness, pallor, oliguria. These all we have learned, we know, because we see day to day these kind of patients, wherein we can immediately diagnose that whether this patient is going into shock. Next slide, please. So, poor uterine tone, tears or trauma, and retained tissue. In clinical findings, if you see when there is a poor uterine tone, if you feel the uterus abdominally in vaginal delivery, uterus feels relaxed, boggy, and soft. Uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and clots. In some tears or trauma, there is continuous bleeding happening from the areas of trauma within the genital tract. Uterine rupture, extension of uterine angles, tears during cesarean section. What investigations we should do is full blood count, coagulation profile, urea and electrolyte, abdominal ultrasound. Of course, these investigation we may not be able to send it immediately, but if there is a continuous trickle, then one of the assistant may take a blood and send it for the investigation, and we can try doing arrest of the postpartum hemorrhage. In retained tissue, clinical findings are retained placenta and membranes identified during bimanual examination. You see, usually in vaginal delivery, we do bimanual examination. Once the placenta is out, then two fingers, that's how we were taught that two fingers should reach the fundus of the uterus, and from above you should palpate the uterine fundus so that you are 100% sure that there is no tissue remain inside the uterine cavity. If at all you feel that patient is not cooperative, then you may do the examination under anesthesia. And in the management of retained tissue, manual removal of placenta or retained products of conception can be done. How do we manage if there is a poor uterine tone? We can use oxytocin, prostaglandins, and ergot alkaloids. Now, there are uterine balloon tamponades also, like Bakri balloon. It's very what can I say? It's very important. You should have to have that balloon, that is uterine tamponade, in the labor room or operation theater. and hemostasis algorithm. See main article for recommended stepwise surgical measures when medical treatment fails. Okay, that this will come to later. Investigation, as I said, inspection in tears or trauma, inspection during cesarean section by exteriorization. Ultrasound may help to identify free fluid in patients with uterine rupture. Now, how do we manage that? Is repair of identifying genital tract trauma and pelvic arterial embolization may be required in cases of broad ligament or supralevator hematoma. For coagulopathy in retained tissue, clinical findings are continuing bleeding, contracted uterus. In investigations, what we should do is urea and electrolytes, of course, CBC and coagulation profile also to be sent. In management, medical management, immediate replacement of blood and coagulation factors and platelets, surgical only with trauma or atonic hemorrhage, which is unresponsive to medical treatment. And the dictum is any patient who is coming for the vaginal labor or cesarean section, we usually two bloods definitely keep it booked. I don't know whether all the gynecologists are doing, but these are the recommendation that we should definitely have to have two bloods ready at any given point of time. And where we feel that these patients have a risk of going into PPH, then we should call for the blood before the vaginal delivery or cesarean section happens. And there should be attempts made to identify the cause in women who are bleeding in parallel with resuscitation. Next slide, please. Now, why we will talk more about the carbetocin, which is a new molecule, of course, and now there are some changes also, right? Am I correct? That it's new heat stable formulation. It comes into. Hello, anybody
Yes,
from?
yes, 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 correct.
Yeah,
Now
okay.
it's heat stable.
Previously, it was not available, right?
Correct, sir, correct.
Okay. So carbetocin is now available in room temperature, stable formulation, and convenient vial presentation. Wherein if you compare carbetocin with other agents, those agents should be kept in a refrigerator to avoid degradation. Now here is the catch. See, whenever it is required to maintain the cold chain, it depends on lot of factors and lot of people also. That it comes from company to a stockist, stockist to a retailer, retailer to hospital. So there is chance of breakage of this cold chain. So that's why we should have to have a drug which is heat stable, which is stable at room temperature. So this is also one of the reasons. And we don't have any heat stable formulation of oxytocin as of now. Previously, formulation of carbetocin was there, which has to be stored between 2 to 8 degrees centigrade. And at least in India, major parts we have a cold chain, we can maintain the cold chain, but in rural areas or in resource poor countries, cold chain is not possible at all. So what should we do for that is shift to a new drug which is convenient to use. And carbetocin is definitely stable at room temperature. It has a shelf life of very long, that is 24 months at 30 degrees centigrade and 75% humidity. And it avoids need for cold chain storage and logistics. And of course, it is conveniently provided in a vial form. Next slide, please. See, what are the molecules available to us is oxytocin, carbetocin, argometrin, symptometrin, and misoprostol. We all use all these molecules. Now, sometimes we use it at crowning, sometimes we use it at the delivery of anterior shoulder, sometimes we use at the end of the second stage of labor, and sometimes we use it following the delivery of the placenta. In high risk patient, definitely we keep it ready and try to use it as early as possible. And its prophylactic use in prevention of PPH and active management of third stage of labor. And in therapeutic use, it is used after the PPH has occurred in the management of PPH. So I think all the textbook, they guide us to use it at the delivery of the anterior shoulder. But we are so busy doing or managing the patient, and everybody is just waiting for that head to come and baby to come. So we just sometimes forget to ask our sister to give at the delivery of the anterior shoulder. So most of the time it is given after the delivery of the baby, or maybe when the placenta is removed, then we give this uterotonic agents. Next slide, please. So carbetocin, a next generation drug for PPH management. It is carbetocin is an analog, oxytocin analog. So it is very similar to oxytocin. It is synthetic, long-acting analog of oxytocin. Therapeutic indication is prevention of postpartum hemorrhage due to uterine atony. And let me tell you that this carbetocin is not replacing the oxytocin. Oxytocin is going to be there. It will stay there because it is used in a lot of other things than managing PPH only. We'll come to that. We have a comparison between oxytocin and carbetocin. Next slide. Yeah, here. So oxytocin, it's synthetic cyclic peptide form of naturally occurring posterior pituitary hormone. It binds to oxytocin receptor in the uterine myometrium, stimulating contraction of this uterine smooth muscles by increasing the sodium permeability of uterine myofibrils. Now, this is the new formulation. Heat stable carbetocin is a long-acting synthetic analog of oxytocin with agonist properties, and it also binds to oxytocin receptors in the uterine smooth muscle, and it results into rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. So, oxytocin is given IV also and IM also. IV, if you give IV, there is an immediate action. Intramuscular, it is a slower onset of action, taking 3 to 7 minutes. And half-life of oxytocin is around 1 to 6 minutes. Carbetocin, if you see, there are sustained uterine contractions within 2 minutes, lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. If you give IM, sustained uterine contraction lasting for about 10 to 11 minutes and rhythmic contractions for almost 2 hours. And the half-life is The longer half-life, that is 40 minutes. Storage, as we discussed, oxytocin 2 to 8 degrees centigrade and carbetocin up to 30 degrees centigrade. Now, the indications. Oxytocin is used in induction of labor, augmentation of labor, prevention of PPH, and treatment of PPH also. Carbetocin, wherein can be used only for the prevention of PPH. So, the thing is, here we have to concentrate on prevention. So prevention, we always say that prevention is always better than cure. So carbetocin is to be used in the prevention of PPH. Next slide, please. So do we have any clinical evidence which backs the claim of carbetocin to be used in prevention of PPH? So yes, there is a champion study which is done by WHO. In that study, it is non-inferiority double-blind randomized trial. And the objective is to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Almost more than 30,000 women patient enrolled across 10 countries, including India. And the primary outcome was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1000 ml. Next slide, please. Now, there is the aim of the study is to establish whether carbetocin is non-inferior to oxytocin or not. So, in judging the efficacy of carbetocin and oxytocin, the parameters were blood loss of more than or equal to 500 ml or the use of additional uterotonic is required. So, here in carbetocin and oxytocin shows the equal efficacy. In blood loss of more than 1000 ml, again the efficacy of carbetocin and oxytocin was similar. Now, when we come to safety, wherein at least one unanticipated event, the safety for carbetocin and oxytocin was similar, that is 4.9% and 4.7%. And at least one serious adverse event, the safety of carbetocin is 0.7% and the safety of oxytocin is 0.6%. So the conclusion was the carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Next slide, please. If we see the Cochrane review, carbetocin for preventing postpartum hemorrhage, they have reviewed the data from 11 studies involving more than 2,500 women. And the conclusion was for women who undergo a cesarean section, carbetocin resulted in statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next slide, please. So we'll see the guidelines from various societies, that is Society of Obs-Gynae of Canada, Danish Society, Ministry of Health of Russian Federation, Mexican National Center for Health, Philippine Obstetrics and Gynecological Society, Queensland Maternity and Neonatal Clinical Guidelines. All of them supported and they have contributed in this PPH prevention. What WHO said in 2018 is only one of the following agents can be used in PPH prophylaxis, that is oxytocin, carbetocin, misoprostol, ergometry, oxytocin and ergometry. What the Canada Society says is carbetocin 100 microgram IV bolus should be used in PPH prophylaxis. Same FIGO also has a recommendation of carbetocin, one of the agents to be used for PPH management. In Germany, Austria, Switzerland, all of the bodies says that carbetocin to be used in the PPH prophylaxis. Even the FCOG of France has recommended carbetocin on proving non-inferiority to oxytocin, and which is, of course, achieved by a champion trial. Next slide, please. Now, yes,
Sir, coming to your experience, since how long are you using Carbetocin?
it's more than 2 years now.
Okay.
More than 2 years, I'm using carbetocin
And generally you use intramuscular or intravenous?
intravenous.
We'll go through the questions, sir. Your experience we'll discuss here. Well, what do you feel is the benefit of using Carbetocin as the first line drug to prevent PPH?
See, of course, prevention is the question itself itself answerable. That prevention is always better than cure. So that's why the carbetocin has to be used in prevention of PPH.
And as first line, first drug?
Yes, first line drug.
Yes.
Only thing is where the labor is augmented or induction is done by oxytocin, and then there we cannot use this.
Oh, that's another question, in fact. And what is the patient profile where doctors can anticipate? We can anticipate PPH in any patient. I mean, every patient is at risk, but
Yeah,
generally,
see, as a gynecologist or obstetrician, you should be ready for PPH.
absolutely,
Which which patient may turn out to into PPH, we don't
we
know.
do not know.
So we should be ready, but the patients where there is episode of PPH happens in previous deliveries. In multiparas, there is chance of PPH. In twins deliveries, there is a chance of PPH. In PIH, there is a chance of PPH. The previous cesarean section, there is a chance of PPH. These are the indications where
Anemia is a risk factor, sir.
GDM, all these patients are high risk.
Anemia is a risk factor, sir, in our country.
Anemia is also a risk factor.
And any experience, I mean, your opinion on use of Carbetocin in retained placenta, of course, after removal of placenta.
Retained placenta, yes, if there is a bleeding, then definitely carbetocin helps. But we don't give carbetocin so late.
Okay, yeah.
It is usually this drug is used for prevention of PPH. So it is given beforehand only.
Beforehand, correct.
And once the carbetocin is given, and if there is a retained placenta or if there is a bleeding, then you can again use your
Yeah,
popular
oxytocin.
drugs
Yes.
or your drugs of choice. There is no contraindication.
RH negative mothers, sir, any experience?
See, I think we have used in one of the patients, and there is no contraindication of
Okay.
using carbetocin in Rh negative mothers.
Now, this was the question, sir. You have answered already. Generally, doctors use oxytocin for labor induction. In such a scenario, can they use carbetocin for prevention of PPH?
No, no,
That's correct.
because those
The receptor should be.
receptors are already blocked.
Yeah. In which case would a doctor prefer IV or IM route?
See, where I suspect that yes, this is the candidate wherein the risk of PPH is there,
Oh,
or where I intend to have the immediate action.
you'll use,
That
yes,
high risk patients, yes, we will use IV
IV.
route.
And I suppose IV is the most commonly used route, I suppose.
Yes, IV is the most commonly used.
And how it's tolerated generally?
That is very well done.
Thank
Very
God.
well done.
Thank God. PPH is a condition, it's good to discuss, but one should never have a patient.
One should not have. So
Yes.
that's why we should discuss these type of
Yes.
conditions very
Correct,
frequently,
correct.
because in these cases prevention will help the
Yes,
patient,
yes, yes.
and ultimately it will help us also.
Absolutely, absolutely. If the patient is not responding adequately with carbetocin, what other additional uterotonics you would use in your order of preference?
See, in that case, I definitely use the methargine.
Methergine.
If not, then oxytocin also
Ah,
IV continuous infusion can be given,
I
and
mean,
of course meso also. But first choice is methargine.
methergine. Of course, the correct answer would be everything available.
Yes,
And what are the advantage of carbetocin? I think the one of the major advantages doesn't require a cold chain, which is important in the peripheral settings,
correct.
pH, vega, etc. Apart from that, other advantage of carbetocin?
Cold chain is not required, that
Yes.
we have discussed.
Yes.
Second, it comes into a
While
vial formulation, and sustained action and longer
long term.
action.
Absolutely.
Second advantage is the shelf life is more than 24
Yeah, yeah,
months.
correct. That's important. The very important practical advantage.
Yes.
Should it be kept as a reserve drug? I suppose today people are using it as a first line. I mean, this question would not be relevant.
Yeah, yeah, yeah. No, no, it has to be used for first line.
And overall, sir, your take-home message for the audience.
Opt the change. Go for new change for good.
Wonderful. एका वाक्यात तुम्ही सांगितलं. Summed it
Yes.
up all. Thank you so much, sir. It was really lovely listening to your practical experience. And in
Thank
fact, that is what the doctors want. Theoretically, we get everything, but then practical and our own doctors using, it gives them confidence.
Correct,
Thank you,
correct.
sir, for taking time for this webinar
Thank you so
attendance.
much.
Thanks
Thank you.
all the doctor who took time and attended this session. Thank you, IT team, Sai Srikar. Thank you. Thank you, sales and marketing team of Hitro for coordinating. Thank you. Sir, you can sign off. It was a
Thank you
pleasure
so
meeting you,
much.
sir. Thank you so much.
Thanks a lot. Oh.
Sai Srikar, thank you.
Thank you, sir.